Well, the reason I like to do community-based research is because it's really important to me that the work that involved in actually involves women and mothers living with HIV. And in this particular project, they've been involved right from the very beginning and then basically on all the work that I do. And fortunately for me, both CIHR and the OHTN have been generous in funding community-based research. And this particular project, Mothers Living with HIV Study, was funded by the OHTN, and which is great. Right, so, I mean, essentially, as Adriana said, my work prior to being engaged in HIV research was with mothers, both as a practitioner, young mothers, and as a researcher. And then when I came to Toronto, I started getting involved with the Ontario AIDS Network, and I was actually the community-based research facilitator there. And that's really how I got involved in HIV work. And through the years, I've been able to sort of go back to my attention, focusing on the experiences and needs of mothers, and in this context, mothers living with HIV. And this study really came from lots of conversations with Adriana and Dr. Mona Lutfi, talking about, where are the gaps. I had done a lot of work on mothers, as well as Adriana and Mona did a lot of work around pregnancy, but there was this gap around what happens right after the baby's born, particularly for mothers living with HIV. We know that motherhood can be a really joyful time. Impending motherhood's really joyful, really exciting, but anxiety-provoking for anybody, regardless of whether or not we're living with HIV. But we wanted to get a better sense of, what are the actual unique experiences of women living with HIV around pregnancy and in that first year of motherhood. And that's, essentially the background. We wanted to really get a sense of, what are the structural issues, the social issues, psychological issues, particularly issues around HIV-related stigma, disclosure, that actually come into that experience and perhaps shift some of the interactions they have with folks in their lives, with healthcare practitioners, social workers. And we figured the only way we could do that would be to ask women themselves. And that's really how this project began. So just to give you a little bit of background around what we know about mothers living with HIV in Canada, we know that they're increasingly having babies. And if anybody has seen the work that Mona Lutfi is doing, we know that there's lots of issues around fertility planning and support around that to support women to have babies. And it's becoming much more normalized with the advent of ARTs and the vertical transmission being very, very low. And in most cases, we rarely hear about it in Toronto or Ontario. It's very rare. They do happen, but it's very rare if women are on medication that babies are born negative. We also know that women living with HIV want to have babies, right? So in this particular survey, 69% wanted to have children, and 57% of those women expected to conceive, and that certainly has come through in our project. But there still are unique issues that we wanted to explore more in depth. We wanted to get a sense of, is there an increased rate of depression for women when they're also at the same time having to deal with perhaps disclosure, who have they disclosed to, who knows, who doesn't know, just the regular issues that impact women to have postpartum depression. We wondered if they might be different or similar for women living with HIV. And we already knew that women who perceive a higher rate of HIV-related stigma did report higher levels of depression, more anxiety, and we really wanted to see, how does stigma and self-esteem impact the overall experience of pregnancy and motherhood. And again, as I said, we wanted to really get closer to the issues of disclosure, stigma, and what do we know about how women feel about HIV in connection to their relationship with their babies. So there's some unique perinatal procedures that we also thought would impact women's experiences of pregnancy and essentially birth and those very early days of motherhood. So for example, some women may either elect or require cesarean section. Obviously, mothers are given AZT. After delivery, AZT is given to the infant for 6 weeks, regardless of the mother's count. So we wondered how that might be experienced by women. There's also virologic testing of the infant, and how would that be experienced for the mothers. And, for example, one of the things that we do know is that even if a woman has been told countless of times by her physician that the baby's negative, until that final test is done, they don't fully breathe a sigh of relief. There's still a slight level of anxiety and curiosity around, what is the actual outcome going to be, right? Okay. The other issue that has become a particularly important issue for me that I work a lot on is around breastfeeding and HIV. So as you may or may not know, because HIV can be passed through breast milk, in Canada, women are required not to breastfeed and are told to exclusively bottle feed. And that raises a whole other issue, particularly in a society where no matter where you go, you're told that breastfeeding is better for your baby and that your baby will have better outcomes if you breastfeed as opposed to formula feed. And the women in our study were very focused on that as being a concern of theirs. There's also other issues that I'll get into a little bit later, but for example, if you haven't disclosed to your family and friends and you come from a culture where if you don't breastfeed, people are going to ask a lot of questions around that. There's a lot of anxiety and concern around inadvertent HIV-related disclosure and stigma that comes from that as well. The other piece is that because of the diversity of our group, and for many women who actually aren't from Canada and come from countries where breastfeeding is the norm as well, even if you're positive, it's quite a shift in your own psyche to think, okay, I thought I was going to be able to breastfeed and now I can't. So there's a lot of differences in how the breastfeeding guidelines look in different places in the world. But in Canada, we're dealing with the issue of complete breastfeeding avoidance, and that comes into play around experiences of motherhood as well. So our study, it is a community-based research study in the sense that we involved and have women living with HIV in our team and working on the study, or our study's wrapped up now, but have been working on the study. They helped to develop our logo as well. But we also needed to use a whole range of methods to get at the data that we wanted to get. For example, like an understanding of rates of postpartum depression or social support and stigma. So we did a mixed method study where we actually did surveys in addition to one-on-one narrative interviews with women, and we collected clinical data as well. And our overall goal is really to enhance our understanding of the psychosocial experiences and needs of women living with HIV across Ontario in pregnancy in the first year of motherhood. We collected data at a number of different times. We met up with women in their third trimester, at which point we got their clinical data, they filled out the surveys, and they actually had an in-depth interview with a peer research associate. And then we met with them again at 3, 6, and 12 months. The interviews happened at baseline, 3 months, and 12 months postpartum. We enrolled 77 women. Most of them have stayed throughout, although we have had a little bit of drop-off, but just what's to be expected. So that's been really great. Mothers living with HIV have actually been involved in data collection, like I said, doing interviews, doing surveys, and also in analyzing our data, and have been involved in presentations, community presentations, and in writing papers as well. So I just wanted to give you a sense of who the 77 women are that participated in our study. I won't go through everything because I don't want to take up too much time, and this is something that you can read. But some really important pieces that we wanted you to sort of be aware of is that actually the majority of the women in our study are from Black or African communities, 66.2%. Place of origin, where 57% were from an African country, and we are really careful about actually naming those countries because it's really important for women to have as much anonymity as possible. And that 42% were actually not in a relationship at the time that they were involved in our study. 9 of the women received their diagnosis at the time that they became pregnant or found out that they were pregnant. And 27% of the women in the study, this was their first baby. Oh, was that? Yeah. This just gives you a sense of the number of children that women had. Another really important piece for us has been the number of women who have had children's aid involvement, not necessarily themselves, personally, although some of them had, but with their children. So their relationships with Child and Family Services as a result of something going on at that time with their own child, which we actually find to be quite high. And we're actually doing work on that now. 98% were on heart in their third trimester. Right, so 55% were Canadian citizens, 27% permanent residents, almost 9% were refugee, and 8.6% other. 47.8, so almost half of our participants were on ODSP, which is also pretty significant. The good news story is that all of the women were stably housed at the time of the study. So because I am a qualitative researcher and I'm not the one that analyzes the numbers, I analyze the stories, I'm going to be focusing on some of the qualitative data. This isn't all of it. If I were to do that, I would be here for a couple of days. So I've decided just to focus on some of the really significant and important and I think compelling stories that the women shared throughout the year or more, year and a half actually, that we've gotten to know them. So as I said, we visited them in pregnancy, postpartum, and a year after the baby was born. And we wanted to really think critically about how we could, do data collection in a way that really put the women's voices at the center of the research. And so what we decided to do was actually not have like a list of questions that we wanted to ask them. We thought we might want to do that, but we changed it and thought, you know what, let's just ask women when we first meet them, like what their experience of being pregnant has been like. What their experience of being a new mother has been like. And they'll take us in the direction that they want to take us and tell us the stories that they want to tell us. And not surprisingly, many of those stories were shared across the 77 women that participated. So the stories that I'm sharing with you today are the ones that were most significant and repeated over and over again by the women. As you know, one of the things that we did after we finished the mothering study was that we took our study results and went to British Columbia, talked to mothers there, other parts of Ontario, talked to mothers here, and to Saskatchewan and talked to mothers there so that they could hear what we were hearing and then tell us what they thought about this. Did these experiences resonate with their own experiences? Were there other questions or issues that we hadn't captured that we thought were important? And for many of them, again, their stories were shared. And the data really did resonate for them. But what they really liked was the storytelling process. And as one of the women said, this is a woman from Saskatchewan, she said, everyone has a story to tell. Everybody comes from a place. Sometimes they aren't the best places. But to be a good person and be in a good way, to be a light in people's darkness all the time, that's what I always tell people, especially nurses too, that are dealing with our women that are HIV, like be a light in somebody's darkness. And I thought that was really important, and that's really the message that I'm hoping to convey by the end of this talk today, is that these are some things to think about in the frontline practice work that you all engage in. So I think I've got 4 or 5 stories, and the first story is really about the social construction of motherhood and how this idea of what it means to be a good mother plays out in the lives of mothers living with HIV. And as one woman said, when people hear that you're HIV positive, they automatically think, okay, you shouldn't be having babies, and then it's defending my right to have a baby. And these conversations take place in the daycare with another mother, on the bus, in conversations with doctors and social workers, and it's a constant theme. There's this idea of how to do motherhood, and HIV is sort of marginalized in that conversation, right? Particularly in connection with their relationships with Child and Family Services, whereas one woman said they don't think I should have a baby, they don't even think I should be pregnant. So the gaze of others that women living with HIV are under really result in having their authority as pregnant women and mothers undermined, challenged, and at times just basically appropriated or taken away from them. And then, not surprisingly, we heard many, many different kinds of stories around HIV-related stigma and discrimination as it related to pregnancy and motherhood. And it is that stigma and discrimination that really changed the pregnancy experience for some women. Many of the women had anticipated at some point that they would become pregnant if they hadn't been already. And for those actually who had had babies prior to an HIV diagnosis would actually tell us in their stories the differences in their experience of what it felt like because of the HIV-related stigma and discrimination that they were experiencing. And one of the ways that they experience that is through having people constantly looking at their file, having to identify them as somebody who's living with HIV. And we've even heard stories where women have had no problems at all, very straightforward pregnancies, no issues. They have their physician, no child and family service involvement, a pregnancy like I would have had. The only difference being that they would have been on ARVs. And yet, at the time of birth, a social worker coming in and visiting them because they've been identified as, a special case or a potentially problematic person who needs some kind of level of support or additional looking into simply because they're living with HIV. And we know that that isn't actually the case, right? Stigma and discrimination also happened at the time of birth, right? One woman talks about, and this is a woman who actually had planned to give birth in a hospital where she would have received appropriate and supportive care, but because of the circumstances and having the baby early and not being in her hometown, she ended up having to go to a different hospital. And in that experience, came up against a doctor that was completely, uneducated about HIV. And so she says, the doctor came in and said that we're not equipped for AIDS. And I started to cry. I yelled out that he had bad bedside manner, that this is a hospital, this is a place to feel safe, not discriminated. He looked at me and he says, I don't even want to hear how you got it. He came back into the room and he had a shield on. He had gloves right up to his shoulders. He was totally covered. I mean, was this guy going deep sea fishing diving or was he preparing for a baby? So for her, it was just like shocking. And in her mind, she knew that she was undetectable. And this guy was not, and with universal precautions or anything else that we're told to deal with in hospital settings or healthcare settings, he was not going to be at risk of HIV, and made her feel as if she was like, a vector of disease, essentially, at the moment that she's having her baby, which should be a joyous, loving time. And essentially took that away from her. We heard other issues. The nurse came in, and she had guests in the room at the time. She had a friend and a family member who did not know about her HIV status. The nurse comes in and said, okay, your baby, she's okay, her status, and your situation, like I know you have HIV, and the formula's already set up, you don't need to worry. She didn't tell me, I need to talk to you, is that okay? Privacy, whatever, nothing. She just boom. And on one level, this is a story about disclosure and inadvertent disclosure, but on another level, it does make you think about, again, HIV-related stigma and discrimination, like how you actually treat people. If this had been another health issue, would there have been a different way of talking to this woman when she had people in her room? She's not an object that you just go in and, share information. Discretion, support, and sensitivity is needed in that particular situation, and it just simply wasn't there. And so what are the consequences of these experiences? Well, for some women, as one woman said, it definitely makes you reflect on whether or not you would do it again. She may have wanted to have other children, but does she want to have to go through that experience again a second time? For her, it was pretty exhausting to think about having to do that. And when I think about the whole process, she says it's nice to have it all done and not have to keep going to doctors and just to get on with her life. Now we can just have a normal life. The making baby part, the whole thing brings it back to the forefront. And so, again, she's really showing us that there's a difference between what she considers to be a normal life, where people aren't looking into every aspect of your experience, and just being able to get on with motherhood, which for her didn't happen until after the baby was born and after she was at home, all the testing was done. It was really an exhausting and emotional experience for her. So the other important issue that emerged that I alluded to earlier was around breastfeeding and the impact that this has on the experience of the mothers in our study. Now, this is not to say that all women in our study felt that this was an issue. There were some women who were actually quite relieved that they didn't have to breastfeed, that they were sort of exempt from that pressure, or they had never wanted to breastfeed. But for the majority, not being able to breastfeed raised multiple issues, right? One of the main issues that I feel that healthcare providers and social workers need to be really aware of is, as I was saying earlier, the degree of questioning and pressure about breastfeeding that enters into their lives, and that unique place that they're in because they've been told not to breastfeed, and the connection that that has to their HIV status impacts their experience in those early days. So, and this isn't coming from healthcare providers, this is actually mostly coming from family members or friends who expected these women to be breastfeeding. So one woman says, she kept asking me, and this is, I think, her sister-in-law, she kept asking me, if I'm breastfeeding, and I told her, yes, I was breastfeeding. She came and asked me again. I was getting upset, but I just didn't want any misunderstanding. Like, why will you keep asking me the same question? She's a doctor, so she really knows how to ask the questions. And so for her, she felt like she just wasn't being left alone. And it was pretty scary for her. And so as a result, as Lydia was saying, there's also, I don't want my friends to come. I don't want them to come to the hospital to visit me because they're going to be like, why, you can't breastfeed. Why are you bottle feeding right away? And I can't say, oh, well, the baby wouldn't latch on. Like, I can't say those things because you can see I haven't even tried. It's a big thing for me to come up with something to say. Just a further point about that is, again, for us to think about what is the work that we can be doing in our clinical settings or our social care settings to start talking about this with women before the baby is born, to help them to develop strategies to come up how they're going to work through the questioning and the pressure, because they really do need a plan, and they're figuring out how to plan for this on their own, but they're on their own, and really what they're needing is somebody to help them and support them through that process. Another issue that came up was just not getting the kind of information that they wanted or required around breastfeeding. And one woman talked about, I asked the doctor after he told me that I'm not supposed to breastfeed, what's the best milk, what kind of milk or the best one I should give to the baby. And the doctor told me, well, it's not his job. I was afraid to ask the other doctor because they're telling me not to breastfeed, but not extending or giving me any other options. I was afraid that the other doctor would also tell me it's not his job, so I kept it to myself. Now, most of us know that women can be referred to Teresa Group for their formula feeding plan program, which is great. But if you're not educated and you don't know, you're not going to be able to support women in accessing those kinds of programs. And we happen to live in a very large province where maybe in Toronto you're going to get that information right away, but there are definitely pockets and places where women are not getting that information. And in fact, one woman in our study who knows a lot about HIV and knew a lot before she had her baby wasn't even told about Teresa Group and ended up taking money out of her own pocket to pay for formula without getting the financial support from Teresa Group. And she could have easily had that. The other important piece that I want you to think about around this is that there are implications. So if a woman is told not to breastfeed and that she's required to use formula, that's one thing. But if you don't feel you can ask anybody about that or talk to anybody about that, there are concerns, and we know that there are concerns that the woman might ultimately end up breastfeeding anyway for all sorts of reasons. In addition to the earlier quotes that I was showing, that pressure is insurmountable. Women may feel for cultural safety or because around safety, around disclosure and discrimination, that they are in a position not to do anything else but breastfeed. But certainly without the added support and information from that frontline person who's with you in the room to say, well, this is not my job to talk to you about this. This is another sort of door that's closed for women to get support. And particularly in our climate around the surveillance of social workers and the legal world. This is really an important piece of information that we need to think about critically and how to support women more effectively. And then the other piece is just that tension that women end up experiencing between doing what they need to do to protect themselves by not disclosing their status as being the reason for not breastfeeding, but dealing at the same time with the feelings of lying and having to make up stories, which doesn't exactly feel great for a lot of women either. If they've been supported adequately by their nurse or social worker or physician around that support piece, that issue can be worked through. But without that, as this woman was talking about, I don't like lying, but I don't want to start explaining too many things. And even using that word lying is pretty powerful and raises concerns around what does this do for women's sort of self-esteem and ways that they feel about themselves in those conversations that they're having with family members and church members, so on and so forth. And so the fourth story that came up a lot in our study was around women's experiences, mothers' experiences of child protection. And this experience came up very much not only in Ontario, but when we went back and talked to women in British Columbia and Saskatchewan, this was hugely significant to women and really felt that although perhaps social work involvement was not as a result of them being HIV positive, it certainly exacerbated the negative relationship or inability to have an open and honest connection with their social worker working for Child and Family Services. So this one woman says, I'm open with people like other professionals because I expect that respect and being professional, right? But she, the CAS worker, ended up turning it against me and saying, well, you could drop dead at any minute and you shouldn't be around the kids. You shouldn't risk them. They're not very knowledgeable about that. And this continues to come up, working on a project right now where we're developing a training module for child and family service workers, also funded by the OHTN. And as we've been working on this project, we're hearing from mothers about their interactions with social workers who, when they discover that there's bed bugs in the apartment, that they make comments about the potential for the bed bugs to transmit HIV to the baby, right? I mean, this is in 2014 that women are being told this. We've been told other stories about children being apprehended because a social worker saw the mother changing the baby's diaper and had concerns about this being an opportunity for neglect. Fortunately, the doctor stepped in, the physician stepped in, and things were sorted out. But can you imagine what it's like, to be thinking my baby's being taken away from me because I changed their diaper? So it may sound crazy and ludicrous, but it's a reality. And again, that continued sort of stigma around, well, how are you supposed to be a parent? If you're positive, you might drop dead. So years and years and years ago, the only writing around social work practice and supporting women living with HIV was really around orphan, thinking about these children are going to be orphans or planning for the possibility that their mother wouldn't be around. And we know that things have changed, right? But social workers are still in that old mindset, many not understanding that, things have changed significantly. And really what they shouldn't be planning for is death, but actually how to support a mother to deal with issues like stigma and discrimination as it may come up in either her life or her child's life. The other role that we found out that social work liked to play, or often played, was around taking a surveillance role around medication, which was really the jobs of, we understand to be the job of nurses and physicians. And so, feeling that they need to be speaking to this woman and making sure that she's taking her medication. And it's a really interesting point. It's something that we need to sort of think about more critically, for sure. And I'm not saying there's an easy answer to that question. But what I would like to point out is that this particular social worker in this situation here really badgered this woman around whether or not she was taking her medications on time, for example. And this woman's like, I've done everything I've had to but the CS is still saying, well, you didn't start your medication soon enough, right? Even though the physician is completely engaged, she's completely engaged with her care, the social worker still feels that she needs to take on this other role around monitoring and surveilling. And so what are all of the consequences of this? Well, you know, women don't talk then to their social workers or to their nurses or to their physicians because they're scared to, right? I don't want to ruffle feathers. These are the people that are taking care of me and my son. You know, I just have to shut my face and take it and then take my baby home and love my baby, and what's done is done, right? So the overarching issue that's of particular concern for us and why we do these kinds of talks is to find ways and to think about ways that we can ensure that women don't feel silenced, that they don't feel othered, that they feel that they have a right to being able to talk about their concerns, ask the questions that they have, regardless of whether or not it's their physician, their nurse, their social worker, somebody working at an AIDS service organization, and not be bumping up against continued experiences of stigma and discrimination and of silencing. And as I said earlier, the overarching consequences are for women not to engage in care, right? To engage in things that aren't particularly either emotionally or physically healthy for themselves, and to isolate, right? And certainly there were women in our study who had, because of the degree of stigma that they experienced, really had a hard time accessing care, even care with physicians that were completely supportive, because of the overarching fears that they had about entering spaces where they're going to be identified as a mother who was living with HIV. It's also really important for me to share stories with you that the women talked about in regards to how they dealt with some of these issues and how actually very strong and powerful they were in sort of trying to navigate all of the issues that I've shared with you today. And as one woman said, I'm very blessed I get to be open with my status and I'm willing to educate. If I reach out and only one person hears me, that's one person who's heard me, not 100 who've not, right? So she is in a position in her life where she feels able to disclose her status, to speak publicly about what it is like to be a mother living with HIV. And even if it's going to hit only one person, that's enough reason for her to be open about who she is in the public realm. Another woman talked about feeling like she's an exotic creature because it's not something people hear about. She's talking about mothers living with HIV. I'm not only very open with my status, but I'm also very inquisitive and I'm willing to challenge people's thoughts. So I'm kind of, in a sense, paving the way for other HIV-positive mothers. And I think that's certainly the case for some of the women that were working on our study. For them, being engaged as a researcher and talking to women in interviews, for them, that was another way for them to feel empowered about their status because this was an opportunity where they could sit in shared experience and support women as they shared their stories around stigma, discrimination, and worries and fears that we all have. And women also shared with us their ideas for how we could more effectively support them, right? And these are the stories that we really need to listen to. And so they shared some really positive experiences that they had with physicians and nurses and social workers as well. And as one woman said there, where she went for care, she felt that the physicians there were very understanding. She wasn't being labeled. They were amazingly patient and kind and comforting and understanding, and really just an amazing group of people. And, that's what you really need, even HIV aside, right? So she's actually able to say, I need these things because I'm HIV positive, but actually all mothers, all women who are pregnant and going through that first year of motherhood need this kind of support. They also talked about really important and significant support systems. And as this woman said, if I let the stigma of what people said about this disease allow me to make a completely different decision, to not be a mother, I don't know where I'd be today. And I'm so thankful. If I had any other type of doctors, I would have made a completely different decision. This is the most fulfilling feeling that I've had having a child. And so for her, she's able to speak to how that relationship with her healthcare team actually made not only the possibility of becoming a mother exciting for her, but the whole process of pregnancy and those early days of motherhood equally exciting. And instead of feeling anxious and worried and fearful, she felt really supportive and thankful. And so, when we shift our gaze onto the culture of healthcare, and I really like this quote by Brown, it's like, in showing us how practices, policies, and research approaches can themselves create marginalizing conditions and inequities, we can ensure how HIV-positive mothers are not left feeling diminished and disempowered when accessing health and social care. So if we can take a step back and say, how have I contributed in some way to making it challenging for women to feel okay or excited about being pregnant and becoming a mother? How do we contribute to that idea? And how can we actually shift that idea through the programs that we provide in our agencies, in our healthcare settings, social work settings? What do we need to do? What kind of policies and programs do we need to have accessible to women to shift that gaze from othering women to actually normalizing motherhood for women living with HIV? So here are just a few of the conclusions and implications that we have come up with the women that we've been working with. And one of them is to really look at how relationships with healthcare providers are established and maintained, and how those relationships impact how mothers experience childbirth and the postpartum period. For us to really consider how power dynamics between mothers and healthcare providers affect these interactions. Even in a supportive relationship, there is a power imbalance, right? Where women may feel hesitant to ask questions. For any of us who've ever been pregnant, we know what that power imbalance feels like. Even if we're not living with HIV, that power imbalance is actually stronger in these situations. So, we need to consider that. We also really need to think about more culturally and socially relevant approaches to supporting mothers living with HIV. And I say including attention to cultural safety. So really critically looking at when we're talking about breastfeeding and not being able to breastfeed. And look, there's this great program that, Teresa Group has. We can do all of those things, but we also really need to think about, is this a situation where other issues, where cultural safety might come into place, where we really have to help women strategize around protecting their own confidentiality, what they might be coming up against from family and friends. And we heard this very much so from women from African countries and also women from Aboriginal communities. In particular, when I went to Saskatchewan, that was very loud and clear from the Aboriginal community that we really need to think about what are some of the more culturally appropriate and effective ways we can support women. And so for us, this really calls for the need to collaborate with mothers living with HIV, with researchers, clinicians, and social workers to develop more education, training, and knowledge translation tools for healthcare providers to optimize care and support women postpartum. And we've been doing a lot of this work, like these kinds of presentations, but we've done work with, for example, at McMaster, with the physicians and nurses and healthcare providers there. We just did a forum in Vancouver, again with healthcare providers, nurses, social workers, people working with ASOs, to do this kind of collaborative work, very much in partnership with mothers living with HIV. In many cases, they've been led by mothers living with HIV in their own communities, which has been great, both here in Ontario and in British Columbia. So for us, again, to think, like, how can we work more together to develop practices and policies and programs? And that's all I have to say about that. I'm sure there's going to be some questions, but I really just wanted to acknowledge the mothers who shared their story with us, acknowledge Casey House and Adriana for inviting me here today to share this with you, all of our investigators and coordinators throughout the province, as well as the OHTN and CIHR for supporting our work. And for you, for coming. Thank you.